Rami? So guidelines and protocols. So the guidelines part is pretty straightforward. The protocol part is the interesting part. I actually happen to like this acute limb ischemia topic because it's all the techniques that we've been hearing about all morning for the critical limbs, and you just add on a component of thrombus and you're on the clock. So that's really what it comes down to. So in terms of protocols, we'll see. So acute limb ischemia, certainly you need to know it. A lot of times you get false calls that something's an acute ischemia. It's really usually, sometimes it may not be, it's just neuropathic rest pain and it's not really an acute ischemia, so you really need to know the difference between both. So I'll review some guidelines on that and some of the results that we have. So key take-home points for protocols guidelines is, number one on the list is how much time do we have, and it's in simple layman's terms, is it salvageable, and what would be the appropriate technique? And a lot of that has to do with what vessel bed we're talking about, what is the underlying pathology, if any, and what is the source of the thrombus in terms of coexisting conditions. The time is critical, so you want to see where you captured along this thread. Is it viable, is it threatened, or is there irreversible damage? And a lot of that has to do with pre-existing pathology, because having coexistent disease or critical limbs of ischemia sometimes may be protective, but sometimes it puts you under the clock a little bit more than is necessary. So it seems simple. We learn a lot of this in med school, but it's the same P's that we talk about. There's a component of pain, certainly. There's a pallor. Those sometimes not so easy to decipher, but you start seeing paresthesia, paralysis, that's when the problem really starts. The cold temperature certainly can be an issue, and absent pulses with people with coexisting disease is going to be coexisting. Unless you have it on the opposite foot, that's full palpability. You know you're dealing with the neurologic exam as a more critical part. So, guidelines. Discussing guidelines, the critical part first is categorizing the ischemia. And I think it's pretty clear. Most people like to use the Rutherford classification. So it's pretty simple, 1, 2, and 3. 1, the limb is not threatened, it's viable. You have no sensory loss, no motor loss, but you have signals in the arterial and venous system both. That's pretty simple. Jumping down to the bottom, you have no sensory function, motor function is gone as well, and there's nothing audible, either arterial or venous. So really the area that we want to focus on, and although I'll change this, I think the area we should focus on is the stage 3, because I think people with expertise can really make an impact in this population on the level 3. But level 2A and 2B, the difference is sensory loss versus sensory and motor. That's 2A and B. The signals, obviously pressure dependent, but usually you lose the arterial. There may or may not be a venous signal present. So, AHA guidelines, acutely painful leg, you suspect ALI, it's a clinical evaluation. You start your evaluation on exam in terms of Doppler motor, give anticoagulation, and most of the data is pretty self-evident. You know, if you're category 1, you'll get some urgency there, you anticoagulate, you treat as necessary. Categories 2A and B, the real decision is it salvageable, how quickly, what is the underlying patient condition. The area I want to focus on really though is the level 3. So category 3, based on recommendations, is you have no motor or sensory function, no cap refill, should you go to amputation? Now, this is what I think as a group of experts you need to decipher, because there's loss of motor and sensory function that, in my opinion, is often still salvageable. It's when you really have rigor mortis and total loss of function that you would proceed to amputation. I think most of these patients should be treated. So that was the American Heart Association guidelines. In terms of the European guidelines, it came out in 2020. The level of evidence of strength as well as their recommendations, just as a frame of reference. There's a lot of them, but I want to focus on some of the key things that I think are worth discussing. The first step is imaging. You know, the general recommendation is the optimal portion of it is probably CTA. I think it gives you the most information, and that's best of their recommendations. You can certainly do duplex and certainly MR, time dependent, but CTA will give you a lot of information about the occlusive level, the thrombus level, the targeted vessels, also pre-existing conditions that exist on the vascular bed, signs of calcifications, and a few other things. What I find interesting is that their class 1 recommendation, although based on level B data, is that If you're in a non-vascular center, you should be sent to a center that has a full range of open and endo options with an urgency depends on the severity. With a lot of work being done in the outpatient, time to travel or transport to the hospital, I'm not sure that's the case. I think it really should be more dependent on the specialty expertise in this area in terms of all the equipment and catheters we have, in terms of getting something maybe to a safer place before transferring or doing the complete work before transferring. Also interesting, for patients with Rutherford 2A, acute limb ischemia, recommended class 1 level A evidence that thrombolysis is the initial choice. In today's day and age, which is only a few years, they're using data extending back in terms of recommendations back into the 3 decades past. TPA certainly is an option, but with the thrombectomy devices, which we could go into, but I know Dr. Garcia is going to be speaking about it, there's some expeditiousness in using the catheter-based therapy. So in terms of using TPA, I'm not sure. I'm kind of questionable on that one. And they're saying that the use of aspiration mechanical thrombectomy should be considered as a class 2A recommendation, but hopefully we'll get into some of that. So why all this fanfare? Because you're talking about an acute situation where the risk of limb loss is high, over 50% in an acute limb ischemia, with a mortality rate that's extending up to 20%. So you have to consider your options, surgical versus catheter-based. Surgical, basics, most simple form is if there's just clot of thrombus there, there's no underlying pathology, you do an embolectomy. But if embolectomy alone is not an option, you always have the surgical options. Catheter-based includes pharmacologic in terms of TPA or urokinase, depending on what part of the world you're in, and as well as the mechanical component with it, which is aspirations of various modalities. Traditionally, surgery was more expeditious. I think that's debatable now. I think based on skill set and equipment available, that might not necessarily be more expeditious than catheter-based therapy, and certainly open to some questions. So, in terms of guidelines and protocols, going back historically, it all started back in the 90s where they compared surgery to thrombolytic therapy, and a lot has changed over the years, but basically the premise has been the same. It's a time issue. Early on, without much threat, TPA works and works well. There's maybe a little bit more of a bleeding risk. When there's more organized thrombus and the time is of essence, maybe surgical options are better. So, recently, something came out which is interesting. National Registry, 10,000 patients with acute limb ischemia out of Japan. After propensity score matching, they said that the hospital mortality, major amputation rate, death rate, hospitalization, and costs were higher for catheter-based therapy versus surgical therapy. I find that kind of interesting because I think these are current results, 2012 to 22, I believe it was, that we could probably do better on the catheter-based approach, but certainly it's always nice to know that you have open surgical options. Not a surprise, 45 hospitals compared endo versus open versus a hybrid approach, and they basically found that there's certainly a benefit to endo or hybrid, and I think ultimately that's what really should be looking at. Most of the data that we have today is of low quality in terms of suggesting protocols. I really think it's an awareness of what your skills are, an awareness of the time, and not burning bridges, and considering options that may exist surgically that you don't want to interfere with, but using a whole toolbox worth of information targeted to the patient rather than just looking at them as an acute ischemic patient. And I say that because surgical outcomes in the context of acute limb ischemia are not the same surgical outcomes as open surgery. Certainly there's time issues that you're dealing with, but we know the blood loss is longer, the surgery is longer, the use of prosthetics is higher than you would expect than an elective setting, and major adverse events are significantly higher than the standard surgical outcomes. So they start touching upon revascularization, whether open versus endo. It should be the initial treatment. Should there be bailout treatment? Should be a combination of treatments, endo versus TPA, and then surgical if needing a bailout. And a lot of it is poised against the outcomes in terms of surgical versus combined and hybrid. I think a lot of it is pointing to the hybrid model. If you really want to look into the nuances of what particularly we talk about with a hybrid model, in addition to chemical, is thrombectomy catheters. As I mentioned, Dr. Garcia is going to get into that, so I won't really touch upon it. But most of the data for the thrombectomy catheters dictate that, they're trying to break it down into more specific categories, what type of equipment, what vascular bed are we talking about, ultimately to show that they're safe and they're successful in alleviating the clot burden and getting the circulation improved. There's even scoring systems to do so. And ultimately, if I have to say, the real question is, how much time do you have? How old is the thrombus? How threatened is the leg? Are you dealing with native circulation versus presence of previous grafts or stents? Is it an old embolus that's been there? Is it just an acute thrombus? Really noticing when a leg is truly unsalvageable before you declare that nothing can be done. Confirm whether you have lysis as an option is a suggestion I always think is critical, because it's always a good bailout if you shower and you lose a target vessel, that you could have the lysis to re-expand that target vessel versus not, in which case you burn bridges that potentially could have been available as a surgical option. Question for yourself based on skills, whether your time to circulation restoration is quick based on what you have available to you and what your knowledge base is. And also always consider options of filters to not make the thrombus burden potentially worse, and always initiating with identifiable runoff prior, and that you'll end up with both. So an algorithm that I think is critical as a point based on what the data is in terms of protocols. Stage 1, pretty straightforward. Do something within 24 hours. You can use anything you want. Stage 2 and 3, combination of endo, surgical, or both should be readily available to you if you really want to make an impact. But the ultimate area of improvement is the amputation site for stage 3, as the guidelines suggest. I think this is where we can make the most impact. With expeditiousness, knowledge base, and equipment available to us, I think you have the biggest impact on limb salvage and saving of amputation rates by addressing the stage 3 group and see what can be done from that. I had a case, but I'm going to forego it here because of time, and we'll continue on.
Alfio, that was really a good talk. Thank you so much. I think you're